have slightly changed the title of my talk to focus on treatment, because I thought that it would be too broad to talk about prevention, etc., etc. And because the next talk will be on the new drugs, so I wanted to focus on the old drugs that you are still using in HIV, HBV co-infected patients. And first of all, just to set up the scene, I'd like to remind you of the global epidemiology of co-infection. You know that when you look at the two maps here, the prevalence of HIV on top and the prevalence of HBV at the bottom, you see that the two viruses affect the same part of the world because they share the same routes of transmission. And about 90% of HIV-infected patients have markers of prior HBV infection, which makes about 5 to 15% of chronic infection. About 2 to 4 million people around the world are infected with both viruses. And in Europe, the prevalence of co-infection is about 7.1%. But you see from this paper that the prevalence has been evaluated in EuroSIDA, and it's quite old, back to 2010. So maybe it has slightly changed now. The routes of transmission at age at transmission differ, and it explains why there are mainly two different zones in the world with different endemicity of HBV. So in zones with low HBV endemicity, like Europe and North America, the transmission of HIV happen through IV drug use and sex, and the prevalence of both infections is about 5 to 10%, but in zones where there is a high HBV endemicity, more than 8%, like Africa and Asia, where the transmission of HBV is due to perinatal transmission or at young age through injections, scarification, prevalence of HIV-HBV is closer to the prevalence of HBV, around 10 to 15%. So what do the guidelines tell us about the treatment of HBV in HIV patients? If we refer to the EACS Guidelines, all persons with HIV-HBV co-infection should receive ART. That includes tenofovir. We don't care about the status, HBV DNA, HBeAg status, the fibrosis status. Everybody should be treated with a tenofovir-based regimen, unless there is a history of tenofovir intolerance, and we'll come back to that later. We should maintain tenofovir in patients undergoing immunosuppressive therapy when they have anti-HBC antibody seropositivity. That's to prevent HBV reactivation, and tenofovir should not be stopped in any case in patients with cirrhosis. So regarding those guidelines, how are they applied in Europe? What's the treatment uptake in Europe? And if you look at this paper, again from the EuroSIDA cohort, 953 patients have been included and followed after 2002. And you know that tenofovir has been available to treat HIV in 2002. And later, a lot later for hepatitis B. So the increase in tenofovir use was from 4% in 2002 to 75% in 2015. But there are big disparities between the east of Europe and the west of Europe. If you look, for example, in 2005, the west of Europe was using tenofovir in 42% of the co-infected patients, compared to 7% in Eastern Europe. And and the difference has slightly decreased, but still significantly different. 63% in 2015 compared in Eastern Europe, compared to 76% in Western Europe. But I think that one of the biggest findings of this paper, and we really have to discuss about that, is that they found that there is no association with the decreased risk of liver-associated events in patients treated to tenofovir compared to those treated without tenofovir, all being HIV-HBV co-infected. So I don't know if you agree with that. Who would agree? Who, from your practice, would say that there is no real clinical impact, no decrease in the risk of liver-associated events in patients treated with tenofovir? Co-infected, of course. Now, yeah. So nobody agrees, but that's a paper published in a very good journal. So what would you say? Well, who would be treated with tenofovir and who would not? Probably the ones who are most at risk of having liver events would be treated with tenofovir, and those with no risk would not be treated with tenofovir. It's what we call the bias, an indication bias. So that's really the big problem with cohorts, is that you don't control for treatment. So the ones who are most at risk are treated, but then, of course, they still have some liver events because they are very much at risk of having liver events. And we saw that a little bit earlier with hepatitis C. It's not because you treat and cure hepatitis C that there is no liver events anymore. So that's really a good illustration of indication bias. Anyway, what do we expect from treatment when we treat our patients? Of course, we expect the control of HBV replication. We expect at the end, it to be a path to HBV eradication, and at least in each infected individual, if not globally, it's what we call the functional cure, and Maria Butti will tell us a lot about that with the new drugs. And we look for safety and tolerability on the long term, and finally, we would like the treatment to have a positive impact on mortality and morbidity. So we'll see what are those issues with tenofovir in HIV, HBV co-infected patients. Regarding the therapeutic goals, I told you the first one would be the control of replication. So we want to have an undetectable HBV DNA, and we are pretty good with that when we use tenofovir in co-infected patients. On the long term, and you look at this paper, which is a meta-analysis, 5 years, on the long term, we see more than 90–95% of the patients who are controlled. But if you look at that, it's not 100%, which means that some patients still have a detectable HBV DNA after 5, 6, 7 years, and even 8 years of treatment. So it doesn't mean that the patients are not taking the treatment. It means that they have a residual viremia, which is explained by other factors than adherence. So what are the consequences of residual viremia? We've studied this issue specifically in our French HIV-HBV cohort, and for this sub-analysis, we have included 112 patients. Most of them, 96, were undetectable, had an undetectable HBV viral load, but some, 10, had a transient persistent viremia, which means blips, you know, what we call the blips in HIV patients. And 15 other patients had a detectable HBV viral load. Some had a low-level persistent viremia, you know, below 2,000, but above 60, which was at the time the threshold of HBV DNA detectability, and some of them had a high level of persistent viremia. So we have specifically studied those patients, and what we found is that there is a very strong association with previous severe immunosuppression and persistent viremia. So there is really an immunological issue under the persistence of viremia. If you look at those results, so the VR that virologically controlled, compared to transient, low level, and high level. So if you look at the transient and low level patients, you see that the nadir CD4 cell count is very low compared with the two other groups. And even at baseline and at the end of follow-up, they are still under the threshold of the patients with VR. But if you look at that, the high level persistent viremia, high level, which means a lot more than 2,000 units, you see that those patients are not very different from the ones who are controlled for HBV DNA, and those patients are not controlled. So in fact, it's not really an immunological problem, it's really an adherence problem, and it has been shown by other teams that non-adherence, of course, leads to treatment failure, and in fact, we have shown that those patients have no TDF in plasma, so they're not taking the treatment, so of course, they have a high level replication of HBV DNA. The second issue with the persistent viremia is that the seroclearance and seroconversion do not occur in the patients with transient or low-level replication. So you see that. First, The seroconversion, HBE or HBS seroconversion, is quite rare, but it never happens in the patients with low level or transient replication. However, we have not seen any clinical impact of transient viremia in our patients, even with the 10 years follow-up, and we are now at 15 years of follow-up of most of our patients and no clinical events so far. But they don't get rid of infection. And if you look at the second therapeutic goal that we want to obtain with the treatment, which is HBE or HBS seroconversion, so the kind of functional cure, you see that it's a game that we are losing with the present treatment with tenofovir. If you look at HBE-Ag loss, you see that after 8 years of treatment, again in our cohort, the French HIV HBV cohort, you see that after 8 years of follow-up, only 40% of the patients have lost HBE-Ag, and a very, very small fraction have lost HBs-Ag. So when we compare that to HBV monoinfection, it's a little bit different for HBV-Ag seroclearance, but it's exactly the same for HBs-Ag seroconversion. There is almost no seroconversion, HBs seroconversion, which means the acquisition of HBs antibodies under tenofovir. So why that? Why is it not achievable? Again, in our cohort, we have looked at the quantification of HBs antigen, and we have shown that very, very small fraction have a very steep decline, a fast decline of HBs antigen, and those patients are the ones who are clearing the antigen. So you see 3.6%, but all the others have either no decline or a very, very low decline and then a plateau. So they have very little change in on-treatment HBs-Ag quantification. And the small fraction of our patients who had lost HBs antigen, they have not acquired antibodies, and you see that the maximal rate of antibodies production is mentioned here, but it's just, we have calculated that only to compare with the rate of acquisition in acute infection or in post-vaccination, and you see that it's much lower than in those two conditions, acute infection and post-vaccination. So it's not achievable. So what's the key answer about that? How do we explain that it's not that we can't have a functional cure? Well, the result is here, but because the cccDNA is not decreased with tenofovir, so you see that the cccDNA is a latent virus inside the hepatocytes, and the present treatment, tenofovir, all nucleosides or even interferon, they can't go inside the hepatocyte and get rid of the cccDNA. And we have done this study on paired biopsy before treatment and after treatment, and we have looked and quantified the cccDNA in the patients with HBe antigen or without HBe antigen, and you see that all patients had a detectable HBV DNA replication even after 36 months of treatment, and we have modeled the decrease of cccDNA, and we have seen that there is no plateau and no patients can achieve the cccDNA eradication. So that's why Maria will tell us about the new drugs, and that's why we really need other drugs than tenofovir. So the third therapeutic goal is the safety on the long term. What's the renal impact of tenofovir in co-infected patients? So again, in the same cohort, we have recently published a paper looking at the clinical impact of tenofovir, especially on the renal function over time, so 8 years of exposure to tenofovir, and at the end of follow-up, the patients with a normal baseline function, about a third had a renal dysfunction, and most of them had a moderate renal dysfunction. So the renal function really become impaired during treatment, but not very, very severely. And if we look at the risk factors for renal impairment in our cohort of TDF-exposed patients, we can't compare without TDF because all of our patients are on TDF. But if we look for the other factors, we found age, which is a high risk factors for renal impairment over time. We found the presence of an age-defining illness in the history of the patients. And we have also found that when HBV DNA is not controlled, then the patients had a higher risk of having an impaired renal dysfunction. And the baseline cirrhosis was a factor in univariate analysis, but not in multivariate analysis. So what are the EACS guidelines in case of renal impairment? Document the origin of renal impairment. It's very, very important before you attribute that to TDF. And because for the moment we don't have any other drugs than TDF or TAF, but TAF can also cause some renal impairment. A very recent case report has been published on Fanconi syndrome in HIV/HBV patients on TAF. So don't think that TAF is absolutely neutral on the renal point of view. So you have to document the origin of renal impairment. It can be iatrogenic, all the other drugs that your patient is taking, and you have to make the difference between glomerular or tubular dysfunction. Then, if there is a tubular dysfunction attributed to TAF, you can switch to a less nephrotoxic drug like TAF. And then, if TDF or TAF are contraindicated, you can switch to entecavir combined to a fully potent therapy for HIV. If there is no previous exposure to 3TC, so if you have a previous exposure to 3TC, we know that entecavir might not work in co-infected patients. So in that case, you can't use entecavir. So you use either tenofovir or TAF, maybe better TAF, and you can give the treatment every 2 or 3 days. Also, we have experience with giving treatment with tenofovir, disoproxil every 2 or 3 days, but not with TAF. And you have to closely monitor renal function. So I think that you really should seek advice from a specialist for that. Okay, fourth goal, the impact on mortality and morbidity of the use of tenofovir. And you can hear that I'm not saying TDF, I'm saying tenofovir, which implies tenofovir, disoproxil, tenofovir alafenamide, and all the other new form of tenofovir disoproxil, which are generic. So it's not fumarate, but it may be succinate or et cetera, et cetera. So the impact on morbidity and mortality, again, in our cohort, we have followed the patient for 8 years and look at the evolution of fibrosis with non-invasive markers, and for some of them non-invasive markers, and for some of them with paired biopsy. And you see that only 14% of our cohort had an histological improvement, and 28 patients without cirrhosis at baseline progressed to cirrhosis. So the finding from the Eurocida paper I've shown you a little bit earlier is not completely wrong. There is probably an indication bias, but at the same time, we know that even treating with our patient with TDF do not completely prevent the evolution of liver disease. So the liver fibrosis is mostly stable during long-term therapy with tenofovir, and there might be still some clinical events associated, not associated, but during treatment in HIV/HBV patients. So if we look for the risk factors for transitioning between non-moderate liver fibrosis to severe fibrosis and cirrhosis, and transitioning meaning going from one state to the other, or the other state to the first one. So you see on the table here that progressing towards cirrhosis is associated with age. The female gender is a protective factor. And the immunosuppression is not a factor associated with progression, but the PI, the use of protease inhibitors in our cohort, has been associated with a progression of liver fibrosis. And if we look at the regression of liver fibrosis, the protective factor is the age, younger age, less progression, and the CD4 count, better immuno reconstitution, and smaller risk of progression towards cirrhosis. So if you are interested in this issue of end-stage liver disease in co-infected patients, you have probably gone through this paper, which has been very controversial, saying that there is an association between the use of TDF and the occurrence of hepatocellular carcinoma. And we have wrote an editorial exactly about this indication bias. Tenofovir is preferred during active infection, and especially in patients who are at risk of developing end-stage liver disease. And those who are not at risk may be less prone to be treated with TDF-containing CRT. So this is, again, a very good illustration of the problems we have with cohorts, and to establish the link between an event and the use of a drug. But as I told you earlier, the risk of end-stage liver disease and HCC is not eliminated with the TDF use. We can see that with this very nice study done in the UK, from the UKHE cohorts, very high number of patients, and you see that they have compared all-cause mortality ratio and liver-related mortality ratio in this big cohort divided in HIV monoinfected, HIV HBV co-infected, HIV HCV co-infected, and triple infected patients. And you see that the HIV HBV co-infected patients have a higher risk than the HIV monoinfected patients to die, and to die of a liver cause. But you can also compare with the HIV HCV co-infected patients, and the HIV HBV have a higher rate of mortality. And again, it has been confirmed by this other study performed in Africa, where you see that even when treatment against HIV and hepatitis B has been introduced early, the patients with SAG antigen and a high viral load, HBV viral load at baseline, have a higher mortality rate, higher risk of mortality than the patients without HBV or with HBV but with a low HBV viral load. And anyway, you should not leave this room thinking that our patients are dying a lot, so maybe, treatment is not efficient. Of course, treatment is efficient, and if we don't treat our patients, they will even die. They will even have a higher rate of mortality. And this is proved by this very nice study from the MAX cohort, where you see three different periods, HBV on one side and HIV with 3 periods. And you see that during the period where we did not have TDF, the rate of mortality was very high, 24.4, compared to 8.1 in the period where we had access to tenofovir. And in fact, when you compare with all the other risk factors for liver events, that's from a very nice study done in the French hospital database. You see 40,000 patients hospitalized, and we have looked at the risk factors for dying of liver-related events or non-liver-related events. And you see that the patients who are HBV and HIV co-infected, so all those patients were HBV. So you see that the other way to look at data, not starting from HIV, but starting from HBV. So all those patients, 48,000 patients were HBV infected, hospitalized, and we looked at risk factors for dying. And when we looked at HIV, then patients who were HIV controlled with a very good tree therapy, they were dying less than the other patients with other risk factors outside of HIV, like diabetes, alcohol, etc., etc. So really, the control of infection in HIV, HBV patients is of great importance to control for mortality and morbidity. So what do the EACS guidelines tell us about the screening of end-stage liver disease in patients without cirrhosis? Liver ultrasound and liver evaluation should be offered every year, and in patients with cirrhosis, we should do that every 6 months with a gastroscopy every 2 or 3 years, and more often in case of esophageal varices. And we should definitely refer to a liver specialist when the patient is cirrhotic because of the need to be assessed for transplantation. So just in summary, 5 points. Prevalence of HIV, HBV co-infection in Europe is about 7%, but you have seen that those data are quite old, so I think that there should be a call for update in big cohorts and not only in small hospitals or other settings, but we need more broad data. The tenofovir, either disoproxil, lefenamide, generics, etc., is really the cornerstone of CRT in HIV, HBV patients. Whatever the level of CD4 and the cirrhotic status and the level of HBV DNA, and despite a modest impact on fibrosis progression and the risk of renal impairment, maintaining the therapy is absolutely essential to contain liver mortality and morbidity. And given that the risk of hepatocellular carcinoma and end-stage liver disease is not abrogated by treatment, we should screen very regularly our patients every 6 months in case of cirrhosis, every year when there is no cirrhosis. And that's a point for Maria. I think that co-infected patients should be very early, should be included in the trials of new HBV drug very early in the process of the development, and not waiting for the drugs to be on the market or even on the phase 3 trials. And that's it. Thank you very much.